Today will be the mental health portion of the special populations training. There's actually three sections that we do. One of those is for IDD, the other is for traumatic brain injuries. And then, like I say, today we're going to discuss special populations mental health. So things that we're going to talk about, we're going to hit some highlights. Everything that you're going to see is certainly not all encompassing. We're going to hit on schizophrenia, schizoaffective, bipolar depression, ADHD, but there's many more mental health diagnoses that you will see. These are just some that we're going to highlight in the training today. All right. So what is schizophrenia? We will see tons of clients, especially in our mental health homes, with schizophrenia. Research says it affects nearly 1% of the population. It's characterized by unusual thoughts, often including hallucinations and delusions. I do want to slow down for just a second and talk about the difference between the two. Hallucinations and delusions are not the same thing. The easy way to remember which is a hallucination affects one of the five senses. Typically what we see, you'll hear us say auditory and visual hallucinations, hearing things, seeing things that are not there, but it can affect any one of the senses. Smell, tactile hallucinations, feel like something's touching your skin. But that is a difference. A delusion is going to be those false beliefs in something, believing that you're the center of the universe, believing that you're God, believing that you have these magical powers. Those are not hallucinations. Those are actually delusions. And sometimes you'll get, paranoia, feeling like people are out to get you. Very common for our residents. A lot of them do not like large crowds because it will kind of make the paranoia worse. Seeing law enforcement sitting on the side of the road, those are all things that make them feel uncomfortable and they actually feel like they're being persecuted or they're being watched. Down here, you've got loss of contact with reality. That is very common. Thinking may be disorganized. We'll hopefully, if everything works like it's supposed to, we will watch a brief simulation in just a few minutes on what it's like to experience some of these things. And I think that will help explain why sometimes their thought process is disorganized. Other common symptoms include flat affect. What does that mean? What's flat affect? That is going to be that face, their facial expressions may be very blank, may not show a whole lot of emotion, but again, that's very common. Loss of pleasure in life, inability to participate in activities. So we're going to watch a brief video.
Schizophrenia is a mental health disorder that causes disruptions in thought processes, perceptions, emotional responsiveness, and social interactions. Many symptoms overlap with those of other disorders, such as depression and bipolar disorder. It is often diagnosed from the age of late adolescence to the early 30s, and symptoms tend to develop earlier in males. The symptoms of schizophrenia fall under three categories: psychotic symptoms such as hallucinations, disorganized speech, and difficulty organizing one's thoughts. Negative symptoms or the lack of behaviors, emotions, or motivation, such as avoiding social engagement with others, emotional numbness, or trouble moving one's body, which is also called psychomotor impairment. Cognitive symptoms such as difficulty concentrating and making decisions. The research on the specific causes of schizophrenia are still underway, but experts believe that it can be attributed to a combination of factors, such as one's environment, their experiences, genetic predisposition, and brain structure and chemistry. Because schizophrenia affects a person's ability to carry out everyday tasks, the support and understanding of others can go a long way to help someone not only cope with the symptoms of schizophrenia, but to have a meaningful and healthy life. Some ways to support someone with schizophrenia include: avoid challenging their beliefs or hallucinations. These are real to them. Be respectful and patient. Encourage them to follow through with their treatment plan and recommendations. Treatment can help. Most often, treatment includes a combination of both medication and therapy. with a focus on managing symptoms and work on problem-solving skills. Many people with schizophrenia benefit from having the support of peers who are also living with similar disorders. It's also very helpful for the person living with the disorder to have support from people in their life who have taken the time to understand schizophrenia and how to best be supportive. This can be done through participating in educational programs, online or local caregiver support groups, and personal research. If you believe yourself or someone you know is experiencing schizophrenia, contact a licensed mental health professional for an assessment and to learn more about treatment options. If you're a mental or behavioral health provider seeking information on evidence-based treatment,
All right, so just a lot of this was discussed in the video, and I'll go through them pretty quick. Causes, genetics. When you're interviewing somebody, doing like a pre-admission screening, and you talk about family background, oftentimes you will see somebody with schizophrenia, it will run into family. Psychosocial factors, exposure to viruses, malnutrition prior to birth, and just chemical imbalances within the brain. Who is affected? I like these stats because it lines up with what I see clinically. Anytime that I admit somebody that has a diagnosis of schizophrenia, I always ask, at what age did you first start to experience the symptoms? In men in particular, it's almost always going to be, I'd say 100% of the time, 17 to about 23, 24 will be that range. It's a little later in the females. It's more common in males. But in the females, it affects them a little bit later in life, and it's be very rare to be diagnosed with schizophrenia prior to puberty and after the age of 45. And oftentimes think about what's going on in your life at 17 or 18. Lots of things. Transition. You're transitioning from high school to maybe college. If you're not going to educational track, oftentimes you're shifting from, living in somebody else's home to being booted out of the nest, so to speak, and being on your own. And there's a lot of stress that comes with that. So I do think that has a lot to do with it. I really do. Tons of examples will be, everything was going really well for me until I went off to college. And then things just kind of started to crumble and they had the psychotic breaks. All right, so this is going to be a brief simulation. You'll have to listen close. Some of it's whispers to kind of give you guys an idea of what it's like to hear voices. I tell every group that I talk to, one of the most powerful things that I experienced, I was at a training and they put these virtual reality headsets on me. And to be able to do that and see what it was like to live with schizophrenia and how that person and the voices are responding to their support systems, trying to work with them, it was just eye-opening for me. This is just kind of a similar example. You won't have the 3D experience necessarily, but you'll have an idea of maybe what it's like to hear voices, and it will give you a different appreciation for what the consumers that we're working with are experiencing. We're trying to help them.
Just stupid. Yeah, so everybody knows that. So how are you feeling today? Oh, good. Now, you think you're so clever, don't you? Well, you're not. You know that, right? Breathing. Stupid. You're stupid. You're just plain thick. Well, you go around thinking you know it all, but you don't. You're just plain thick. You're worthless. I'm not even trying. Just admit, you're a loser. No good. Worthless. You go around pretending you can do this, that you're clever than you are, but we know the truth, don't we? You really are. But you're really capable of.
Can you smell that? I smell fire.
Why you even bother?
I smell something burning like plastic or tar or something burning. What's that?
All right. So typical treatment, and very rarely do I say that I look to meds first, but with schizophrenia in particular, medication management is probably the most important piece. You're going to see meds used like Abilify, Risperdal, Seroquel, Geodon, Zyprexa. Most every house has multiple people on one or maybe even a combination of those medications. A lot of times now they're trending towards injectables. A lot of the patients are really liking that because they don't have to worry about daily administration of the PO meds, and they don't seem to mind the every 2 week or every 4 week injections. Psychosocial rehab. So for you guys that do not know, that is how LifeQuest, the day program that most of our individuals attend, that is how they're licensed. And again, that'll help with skill building, coping, and addressing their mental health symptoms. And then there's education and group therapy and cognitive behavioral therapy. All right, so we're going to move on. We're going to talk about a different disorder, and it's called schizoaffective. Of all the disorders that we deal with, this is one of the more common ones. The best way to remember what this is, it's like schizophrenia and a mood disorder, and you take them and you scramble them together. There's components of each. So again, there's going to be, you may have a mood disorder like, depression or bipolar, but they'll also have those psychotic features. And when we say psychotic features, we're talking about the hallucination, the delusion, the disorganized speech, the disorganized thoughts, those things. And it's a combination of those. Again, they're characterized by mood swings, and they sometimes experience those psychotic features. Cause of schizoaffective, because it's similar to a mood disorder or schizophrenia, you'll see some of the similar causes: genetics, brain chemistries, and then environmental factors. All right, so moving on to bipolar disorder. Bipolar is characterized by extreme changes in mood or mood swings. The name comes from bi means two, polar means a pole. So there's two different poles. You've got the mania and then you've got the depression. That's where the name comes from, okay? Mania or manic is going to be that restless, talkative, happy, energetic. They're often reckless. You'll see the typical example is, excessive spending. They may be sexually promiscuous, just taking chances, making bad decisions. Those are the things that you'll see when somebody's in that manic phase. And then we've got the depressive phase. And that's going to be the sadness, loss of energy, no sense of self-worth, crying. Now, it's bipolar. What I want you to know, it's not that I woke up on the wrong side of the bed thing and I'm in a bad mood today. That's not what it is. This disorder is going to be characterized by longer swings than that. It's not going to be that sudden hour-to-hour change in their mood. And individuals can experience normal moods in between these mood swings. Again, they're often difficult to predict and vary from individual to individual. I typically use the example in females, you'll see it. Just say you've got a female consumer and they normally wear just a normal amount of makeup, all right? Sometimes when they're trending towards that manic phase, you'll start to see heavy makeup, bright colors, glitter, those things. So just keep in mind, again, it's different for everybody. But just kind of know your individuals, know your consumers, and then start to look closer when you start to see those swings. So the duration of mania and depression varies and can last for weeks and for even years. And we've already talked about mania often results in reckless behaviors such as excessive spending. Prolonged depression can result in an increased risk for suicide.
Bipolar disorder is a mental health condition that affects a person's day-to-day interactions, behaviors, mood, thoughts, energy, and ability to focus. There are 3 different types of bipolar disorder: bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder or cyclothymia. All 3 types cause symptoms of either mania or depression, or both. Some examples of manic symptoms are unusually high energy, talkativeness, distractibility, and less need for sleep. Some examples of depressive symptoms are feelings of extreme sadness, lack of energy, lack of emotions or motivation, hopelessness, and guilt. The difference between each type of bipolar disorder comes down to when they begin and how severe the manic and depressive symptoms are. Bipolar 1 disorder typically begins around age 18, although onset can occur at any point in someone's life. A person with bipolar 1 disorder will experience manic episodes that are present for at least 7 days and can be so severe that the person may require hospitalization. The person may also experience major depressive episodes or symptoms, although some people with bipolar 1 may only experience mania without any depression. A person with bipolar 2 disorder will experience episodes of both major depression and hypomania. The symptoms of hypomania are the same as mania, but they are less severe and only last up to 4 days rather than a week. Cyclothymia can begin as early as 6 years of age and may eventually develop into bipolar 1 or 2. A person with cyclothymic disorder will experience hypomanic and depressive symptoms, but never to the extent that they qualify as mania or major depression. There is no single cause of bipolar disorder, but research shows that it may be related to several factors, such as genetics, a person's environment, and brain structure. It is common for people with bipolar disorder to have other mental health diagnoses, such as psychosis, anxiety disorders, eating disorders, or substance or alcohol use disorder. Bipolar disorder is a lifelong mental health condition, but with the help of treatment provided by a licensed mental health professional, it is possible to reduce and manage the symptoms. Bipolar disorder is usually treated with a combination of medication and psychotherapy. If you or someone you know has bipolar disorder, don't be afraid to ask for help.
So we're gonna move on to depression. Depression affects a person's body, mood, and thoughts. Typical symptoms will include the following: difficulty making decisions. They're just not feeling like themselves. They're just not feeling well. Feeling tired, feeling hopeless, difficulty sleeping, restlessness, loss of interest in pleasurable things, overeating or loss of appetite, chronic aches and pains, feeling sad, and thoughts of suicide. I think we've all felt that way at some point in our life. There's a difference between clinical depression and just having a tough day. But I think this is one that we can all relate to maybe a little bit better, because we've all, whether it's just a situation that we're going through in life or whatever, I think this one's a little more relatable for people, because we've all to some degree experienced those symptoms. And I think for this one in particular, it's a little easier for us to kind of help our consumers, kind of help them through some of those difficulties. Being we're not going to talk about crisis response today, the very last bullet is thoughts of suicide. I will take a minute and we'll talk about that one. In terms of suicide, one of the biggest myths in mental health is that by you asking them if they feel like hurting themselves, that's actually going to cause them to do that. Okay, that is the worst thing you can do. If somebody comes to you and say they're having thoughts of harming themselves, do not shy away from the opportunity to assess them for safety. The very first thing you do is you say, do you want to harm yourself? If they say yes, you follow that up with, do you have a plan? Now, how they answer that really kind of dictates our next step. The real life examples that I usually try to give, most of the people that have sat through these trainings have heard this one before. It's one thing if somebody comes to you and say they're having thoughts of hurting themselves. You ask them, do they have a plan? And they say, yes, I've got a plan. Well, what is that plan? Well, I'm going to overdose on my medications. Is it possible? Depends. Do they self-administer? I don't know. But most of our clients do not. So the chance of them overdosing on their medications is actually pretty slim, as long as we're doing things the way that we're supposed to do that, and that's keeping the office locked, keeping the med cabinet locked, and those things. So at that point, I think that the risk is a little lower versus the example that I often give. Again, it's a real example. A guy came to me and said, I'm having thoughts of hurting myself. And I said, well, do you have a plan? He said, yes. I said, what is it? Well, I'm going to wait until staff goes to bed at night. I'm going to go into the kitchen and I'm going to get a knife. I'm going to go into the bathroom. I'm going to take all my clothes off. I'm going to lay in the bathtub. I'm going to cut my wrist and I'm going to bleed to death. Now, that one's serious. Okay. They're all serious because even with the first example, they're telling you they need help. But this one turns in, this one's more of an immediate response right away. We're not second guessing ourselves. We're going to go ahead and follow our crisis protocol. Probably going to be an involuntary commitment, hospitalization, figure out what's going on. Do we need a different type of therapy? Do we need a different type of medication, different services, you name it. But the moral of the story is do not shy away from asking them. And it feels really weird. This is a small group today, but normally in a big group, I'll ask, how many of you guys have actually had to ask somebody, are you thinking about hurting yourself? Not many people raise their hands. You know why? Because it's uncomfortable and it feels weird. And you feel like you're actually doing the wrong thing, and in reality, you're not. So especially when we've got interns and things, I usually address this. Just go at it directly because, again, safety is the primary concern, the primary goal. So causes of depression, numerous causes. And this list is certainly not exhaustive. Abuse, medication, conflict, death, loss. When we're writing treatment plans, one of the things that we have to ask is, what are the triggers? What triggers your mental health symptoms? Oftentimes you'll see the passing of a loved one or an anniversary of a loved one's passing. Those things are probably one of the more common ones that you'll see in terms of triggers. Genetic, major life events, personal problems, serious illness, substance abuse. Sometimes just physical, just not feeling well in general. You may have things that are not up here, or hormone imbalances, any number of things. So ADHD, we'll talk just briefly about this one, especially with the rise in our consumers that are on the autism spectrum. We're seeing more and more ADHD. I think everybody's familiar with ADHD, attention deficit and hyperactivity disorder. Again, it's just going to be characterized by that inattention being, having a hard time paying attention, just being easily distracted, disorganized, and then the impulsivity. So, personality disorders. This one is certainly above my pay grade. So I think this guy does a fantastic job. Now you will have to listen closely. He gets really excited and he talks really, really, really fast. But I think he's a cool dude. And I think he is probably better qualified to talk about personality disorders than me. What I'll say before the video starts is we don't have a ton of personality disorders within our agency. Oftentimes I will screen for those. Just historically, we've just not had good success reaching that population of people in the residential setting, and often leads to, and he'll allude to it in the video, just a lot of conflict in the homes and things that just makes progress towards goals difficult. So just listen closely for him. Again, he talks really, really fast.
I can be smooth and charming and slick. I can make a very confident impression, and it's hard to put me at a loss for words. Sometimes I find myself fantasizing about unlimited success and power and beauty. I have repeatedly used deceit to cheat, con, or defraud others for my personal gain. To be honest, I don't have much concern for the feelings of other people or their suffering. Doesn't sound like the Hank you know, does it? These are all statements from a self-assessment measure for personality disorders that lets patients describe themselves, ranking each statement in terms of how accurate they think it is. To be honest, you can't really rely too much on this kind of self-reporting to assess what we're talking about today, because while some people who are overconfident or obsessed with power or downright deceitful might tell you that they are, there's a certain subset that won't. Many of the disorders we've talked about so far are considered ego-dystonic, meaning that people who have them are aware that they have a problem and tend to be distressed by their symptoms. Like a person with bipolar disorder or OCD generally knows that they have a psychological condition and they don't like what it does to them. But some disorders are trickier than that. They're ego-syntonic. The person experiencing them doesn't necessarily think that they have a problem, and sometimes they think the problem is with everyone else. Personality disorders fall into this category. These are psychological disorders marked by inflexible, disruptive, and enduring behavior patterns that impair social and other functioning, whether the sufferer recognizes that or not. Unlike many other conditions that we've talked about, personality disorders are often considered to be chronic and enduring syndromes that create noticeable problems in life. And as you can tell from these self-assessment statements, they can range from relatively harmless displays of narcissism to a true and troubling lack of empathy for other people. Not only can personality disorders be difficult to diagnose and understand, they can also be downright scary. Most of the extreme and severe disorders go by names that you probably recognize: psychopathy and sociopathy. I'm talking like serial killers here, mob bosses, Vlad the Impaler. Cultures have been studying human personality characteristics for thousands of years, but the concept of personality disorders is a much newer idea. Much of our modern classifications of these disorders are based on the work of German psychiatrist Kurt Schneider, who was one of the earliest researchers into what was then known as psychopathy, and published a treatise on this subject in 1923. Today, the DSM-5 contains 10 distinct personality disorder diagnoses grouped into 3 clusters. The first cluster, Cluster A, includes what are often labeled simply as odd or eccentric personality characteristics. For example, someone with paranoid personality disorder may feel a pervasive distrust of others and be constantly guarded and suspicious, while a person with schizoid personality disorder would seem overly aloof and indifferent, showing no interest in relationships and few emotional responses. Cluster B encompasses dramatic, emotional, or impulsive personality characteristics. For example, a narcissistic personality can display a selfish, grandiose sense of self-importance and entitlement. Meanwhile, a histrionic personality might seem like they're acting a part to get attention, even putting themselves at risk with dramatic, dangerous, and even suicidal gestures. The behavior of Cluster B can be truly self-destructive and frightening, and these disorders are often associated with frequent hospitalization. Finally, Cluster C encompasses anxious, fearful, or avoidant personality traits. For example, those with avoidant and dependent personality disorders often avoid meeting new people or taking risks and show a lack of confidence, an excessive need to be taken care of, and a tremendous fear of being abandoned. Now, in the past, and to a great extent today, some of these categories have been controversial. Many researchers argue that some of these conditions overlap with each other so much that it can be impossible to tease them apart. Narcissistic personality disorder, for example, has many traits that resemble histrionic personality disorder. And because of this gray area, the most commonly diagnosed personality disorder is actually personality disorder not otherwise specified, or PDNOS. The prevalence of this diagnosis suggests that while clinicians can identify a personality disorder in a patient, figuring out the details of the condition can be messy and difficult. One proposed alternative for diagnosing these disorders is the dimensional model, which in essence gets rid of discrete disorders and replaces them with a range of personality traits or symptoms, rating each person on each dimension. So the dimensional model would assess a patient not with the aim of diagnosing one disorder or another, but instead simply finding out that they rank high on, say, narcissism and avoidance. It's a work in progress, so with another generation, the clinical definition of personality disorder may evolve pretty radically. One of the best studied personality disorders right now is borderline personality disorder, or BPD. Borderline makes it sound like patients are pretty close to being healthy, but not quite, but that is not at all the case. BPD sufferers have often learned to use dysfunctional, unhealthy ways to get their basic psychological needs met, like love and validation, by using things like outbursts of rage, or on the other end of the spectrum, self-injury behaviors like cutting or worse. People with BPD were once commonly maligned by clinicians as difficult or attention-seeking, but we now understand BPD as a complicated set of learned behaviors and emotional responses to traumatic or neglectful environments, particularly in childhood. In a sense, people with this disorder learned that rage or self-harm helped them cope with traumatic situations, but as a result, they also end up using them in non-traumatic situations. Although challenging for patients and clinicians alike, the good news is that some psychotherapies have helped even the most severely suffering, repeatedly hospitalized BPD patients. But probably the most famous, well-established, and frankly troubling personality disorder is antisocial personality disorder. Now, you've heard of this before, but maybe by one of its now somewhat out-of-vogue synonyms, psychopathy or sociopathy. People with antisocial personality disorder, usually men, exhibit a lack of conscience for wrongdoing, even towards friends and family members. disorders. Their destructive behavior surfaces in childhood or adolescence, beginning with excessive lying, fighting, stealing, violence, or manipulation. As adults, people with this disorder are thought to generally end up in one of two situations. Either they're unable to keep a job and engage in violent, criminal, or similarly dysfunctional behavior, or they become clever, charming con artists or ruthless executives who make their way to positions of power. Tony Soprano would have qualified for a diagnosis even if he wasn't nearly as bad as, say, serial killer Ted Bundy or Vlad the Impaler, the infamous 15th century Romanian prince who personally watched about 100,000 people get impaled or have the skin of their feet licked off by goats. Yeah, that happened. Despite this classic remorselessness, lack of empathy, and sometimes criminal behavior, criminality is not always a component of antisocial behavior. Certainly many people with criminal records don't fit that psychopathic profile. Most show remorse, love, and concern for friends and family. But still, although antisocial personalities make up just about 1% of the general population, they were estimated in one study to constitute about 16% of the incarcerated population. So how might someone end up with such a disturbing disorder? Well, as you might expect, the causes are probably a tangled combination of biological and psychological threads, both genetic and environmental. Although no one has found a single genetic predictor of antisocial personality disorder, twin and adoption studies do show that relatives of those with psychopathic features do have a higher likelihood of engaging in psychopathic behavior themselves. And early signs are sometimes detected as young as age 3 or 4, often as an impairment in fear conditioning. In other words, lower than normal response to things that typically startle or frighten children, like loud and unpleasant noises. Most kids only need to get burned by a hot dish once to know to stay away, but kids who end up displaying antisocial personalities as adults don't necessarily connect or care about the learned consequences when they're little. From there, like we've seen in other disorders, genetic and biological influences can intersect with an abusive or neglectful environment to help wire the personality in a peculiar and damaged way. While the vast majority of traumatized people don't grow up to be killers or con artists, genes do seem to predispose some people to be more sensitive to abuse or trauma. Meanwhile, studies exploring the neural basis of antisocial disorder have revealed that when shown evocative photographs like a child being hit or a woman with a knife at her throat, those with psychopathic personality features showed little change in heart rate and perspiration as compared to control groups. And the classic antisocial lack of impulse control and other symptoms have also been linked to deficits in certain brain structures. One study compared PET scans from 41 people convicted of murder to those of non-criminals and found that the convicted killers had greatly reduced activity in the frontal lobe, an area associated with impulse control and keeping aggressive behavior in check. In fact, violent repeat offenders had as much as 11% less frontal lobe tissue than the average brain. Their brains also responded less to facial displays of stress or anguish, something that's also observed in childhood. So it's possible that some antisocial personalities lack empathy because they simply don't or can't register others' feelings. Research has also suggested an overly reactive dopamine reward system, suggesting that the drive to act on impulse to gain stimulation or short-term rewards, regardless of the consequences, may be more intense than the average person's. As we mentioned before, because personality disorders are pretty much ego-syntonic by definition, people don't often acknowledge that they have a problem or a need for treatment. And in the case of antisocial personality disorder, even if they did, there aren't many specific treatments available, at least not for adults. But there are some promising interventions for kids and adolescents whose minds and brains are more plastic and adaptable. In this way, the best way to treat antisocial personality disorder may be in trying to prevent it. According to American psychiatrist Donald W. Black, among others, many kids diagnosed with conduct disorder, the diagnostic precursor to antisocial disorder, are at high risk for developing antisocial personalities as adults. But by identifying warning signs early on and by working with these kids and families to correct their behavior and remove negative influences, some of that impulse fearlessness could be channeled into healthier directions, like toward promoting athleticism or a spirit of adventure. It's important to remember that antisocial personality disorder is only one type of personality disorder. This is a diverse family of psychological conditions determined by many different factors, and we're still in the early stages of diagnosing and understanding the mechanisms behind them. Today, you learned about personality disorders and the difference between ego-dystonic and ego-syntonic. I can be smooth.
Okay, our role as a primary support. This is the last slide that we've got. Medication administration. One of our biggest jobs and most important jobs is to be able to pass those medications for folks. When I ask people on admission, especially to families, what do you need from us? Almost always I say, we just need to make sure that they're getting their medications and that they're done correctly. This part is key. a lot of these things that we've talked about, the first line of defense will be medication administration or medication in general. Ensuring that our residents receive treatment for mental health. One of my biggest jobs is what we call service coordination or coordination of care. And that is when we take in these residents, we've got to make sure they're getting what they need. Oftentimes they come to us and they've never received services. So we're talking about maybe setting them up with a psychiatrist, setting them up with primary care, individual therapy, a day program, vocational rehab, specialty services for diabetes, you name it. Because just because we're talking about mental health today, all this stuff is linked together. If their diabetes is not controlled, they're not going to feel well. They're not going to feel well mentally. But our job is to make sure that we link them with the providers. We just put a few examples in here. And again, PSR, psychosocial rehab through LifeQuest is one of our more important services, and I think it helps a lot. A lot of our folks come here, they've been isolated, they don't have any friends, they just don't have those social contacts. Being able to link them with a day program does a ton to help with their mental health. Organize appointments and transportation. The general community misses a ton of appointments. I guarantee you, if you called ECU Health, Behavioral Health, and ask them how many no-shows they get, it's a very, very high no-show rate. So we're funny about appointments. Okay, we've got a pretty good, solid system for getting those appointments in the calendar, and it's just really important that we get those things run and we get those run on time. Personal care services, because we hit on it. We kind of went through that list when we were talking about depression. When somebody's feeling down, they're feeling depressed, and they're feeling hopeless, oftentimes the first thing to go is what? Taking care of themselves, those basic needs, those hygienes. Not one single person in the room has woke up and said, man, I feel really down today. I'm going to go get dressed up and take a shower. You know what we tend to do? Lay around, just trying to stay comfortable. So personal care, making sure that we're providing those services. Implementation of realistic and attainable goals. That has really been a focus. We've added a position at Country Living to where we can focus on writing those treatment plans, making sure that we're writing goals that meet the needs of these individuals and that they're their goals, the individual's goals. Again, this isn't a person-centered plan training, but just making sure that the goals that we're writing actually address the symptoms that we're seeing and that they're realistic. Communication. Sit down and talk to them. It will go a long way. If somebody's feeling down, sometimes they just need an ear. Sometimes that person that says that they feel like hurting themselves, sometimes they just need an ear. We've had several cases this week when I really just felt like that person just needed us to be able to sit down, talk to them, let them know that everything's going to be okay. And then early recognition of any symptoms that may lead to a crisis. That is important. It's always in the plan. Okay, know your consumers. Know to know or to recognize these early warning signs down here at the bottom. You've got to know what they're like on a good day. You got to know what they're like at baseline. So just anytime that you see something as a direct care staff, if you see something just doesn't seem right, go ahead and let somebody know. Let your quality assurance supervisor know. Let me know, so we can just make sure that we're on top of that and we can take care of it before it becomes a bigger issue. All right, so 6 P's for success, and we'll run through these pretty quickly. Patience. You have got to be patient. Okay, it is a difficult job. Some days are certainly better than others, but you've got to, again, it kind of goes back to that communication for me. Just sit down, just listen, just talk to them. When they're having a bad day, just be understanding. Persistence and perseverance, I think those things kind of go hand in hand. I look at that really from a treatment planning standpoint. If something's not working, then we need to step back instead of giving up and quitting. Instead of recommending discharge from services, we need to step back as a treatment team and we need to look at other strategies that we can do so the person can be successful. Personality. Everybody has a different personality. Everybody that you work with, every staff member has a different personality. Just be mindful of that. And again, you can kind of link that back to communication. Professionalism. This is our job, and it is very easy. Some of the people watching the video will not work in a group home setting necessarily, but the majority will. Living in the house with them, it gets really blurry sometimes. It starts to feel like your house versus your job or your place of employment. Just be mindful that, when you're clocked in, you've got to be a professional. We're there to help. We're here to help. And, just keep that in mind when you're interacting with the residents. And in positivity, never would I recommend that negativity is the best way to handle any one of these diagnoses that we've talked about today. Be positive, be encouraging. Even when you're having a bad day, that kind of goes back up to personality. When you're having a bad day, you got to remember, it's your job. We're here to help. Be positive. It will go a long, long way. Any questions?